Welcome. Welcome to the Cleveland Clinic. I'm Nick Smadira from the Department of Thoracic and Cardiovascular Surgery. And today we're going to talk about the management of chronic thromboembolic pulmonary hypertension and pulmonary emboli. I have a very distinguished panel with me to help walk through the management of these patients. Gustavo Herresi heads our pulmonary hypertension clinic and is an expert in CTEPH. My colleague Michael Tong is sitting next to him from the Department of Cardiothoracic Surgery and has performed 15 pulmonary thromboendarterectomies so far in 2019. Next to him is Dr. Ehab Hadidin, one of our premier interventional radiologists involved with some of our balloon angioplasty. And the head of vascular medicine, Jerry Bartholomew, will help with the medical management of these patients. So I'd like to start with you, Gus. When you think of the distinguishing between acute pulmonary emboli and chronic pulmonary hypertension, how do you work through those patients in sort of your algorithm of thinking through when you see a patient that may be referred to you for this entity?
Yes, there are several factors that play into that decision making. First and foremost, we like to understand how long the patients have had symptoms. Typically, patients with acute embolic disease will tell us symptoms for a few days. When we hear people complaining of shortness of breath and other symptoms for longer than 2 weeks, that's when we start thinking there may be a chronic component to it. But at the end of the day, of course, the imaging studies are key. We have gotten really good at telling apart acute versus chronic thromboembolic disease using particularly CT scans of the chest. And there are several features on a CAT scan that will point towards acute versus chronic disease.
Do you want to help guide us through what are some of the 2 or 3 things that might make you think that it is more chronic than acute when you look at the CT scan?
So from an imaging standpoint of view, just from an anatomical standpoint, how the clot sits in the pulmonary artery is typically one of the biggest characteristic features. So, we talk about, an acute embolus is something that dislodges from somewhere else and ends up in the pulmonary artery. So it tends to form a different angle with the wall, whereas a chronic thrombus is something that sits there, tends to integrate and becomes really more fibrotic, so that angle that it forms really gets lost and it becomes really more one with the wall. The acute thrombi tends to enlarge the vessel, whereas the chronic, as you look at it very carefully, you actually tend to see a smaller caliber of the vessel.
Is there anything in the distal ramifications that, when you're looking out in the first or second order branches of the pulmonary, that are helpful, or is it mainly that main or lobar that guides you?
In both. And, the distal branches is, if you look very carefully in the chronic disease, you'll sometimes see the webs, the linear filling defects, which you don't see with the acute. And sometimes you actually see a mixture of both, where you have an acute on a chronic phenomenon. But certainly you have to look at the entire distribution of the vasculature.
So, Jerry, if the patient comes in and is kind of indeterminate whether this is acute or subacute, how do you think through your algorithm of management now with all these different choices for treatment in terms of intravenous versus orals? What's your approach in the first line for you?
So for the management, actual acute management?
Or they come in and you're not quite sure, is this acute or subacute, but they're stable enough that we don't have to do any urgent intervention.
Sure. Well, the great advantage is that now we have the direct oral anticoagulants, and certainly if we think it's more acute, we can put them on a number of any one of the different DOACs, as they're called. And we can still use low molecular weight heparin and or warfarin, depending on the patient. And we try to look at each patient individually. Do they have any renal disease? Do they have gastrointestinal problems? And that would help determine which of the direct oral anticoagulants we might want to use. And then I question the patient to try and determine how long they've had symptoms. I also like to get old records and old images to look at as well. And then if I'm thinking it's more chronic, I would probably order a echocardiogram, a 6-minute walk, and a ventilation perfusion scan, and then send them over to my colleague over there, Dr. Haresi.
I don't know the answer to this from as a cardiac surgeon, but if somebody comes into the emergency room with some chest pain, just got off a plane from somewhere a couple days ago, and they get the CT scan and they've got a pulmonary embolism, their SATs are okay. Are they these days admitted to the hospital, or can you put them on a NOAC and send them home without admitting them?
Sure, it's a good question. Can they be sent out? And I think we're starting to learn that, yes, they can be. Many years ago, if you had a DVT or a PE, you were hospitalized for 7 to 10 days.
Right,
and,
right.
We had to convert them to warfarin. Then along came the low molecular weight heparins and injections, and they could go out on those. And now, we have some guidelines that will kind of help us tell, can that patient be discharged? Is he hemodynamically stable, for example? Do they have pain that cannot be controlled or you need narcotics for? What are their vital signs? And then you can use biomarkers as well. Those are just a few of the things that one can use.
And are you suggesting for a team considering, or an institution considering this discharge, that they develop either a care path or an algorithm where they look through these specific things, make a decision so it's more or less standardized? Is that?
Sure, there are online algorithms that you can use. Just type in PE or DBT, and if you get to a certain algorithm, putting in a little bit of information, you can kind of find out exactly what their needs are and if they are a good candidate for outpatient. For example, you want to make sure they have access to medication. You can't just give them a prescription and send them to the corner pharmacy. Make sure that they have that DOAC, for example. That's one other thing. But yeah, it's a different world.
So we'll stick with acute pulmonary embolism for the moment, then get into chronic. So let's say now the patient is hemodynamically unstable. We're given multiple boluses of fluids. They're on increasing doses of inotrope. The echo shows that the RV is quite distended. There's this big embolus in the main and lobar PAs. How, Mike, do you decide whether we should go and operate sternotomy? When is ECMO an option for these patients, or when do we send them to EHAP to do some sort of interventional extraction of the clot? How do you think through those steps?
So we have an entire team called the PERT team, PE response team, that helps make that decision. So when a patient arrives to hospital or they're already in a hospital, anywhere in the hospital, and there's suspicion of a PE and it's confirmed by CT, the PERT team is activated. And then you have a multidisciplinary team. All of us are members of the team, along with our critical care colleagues and other members of the team and pharmacists. And we'll look at that patient, figure out what is the best treatment approach for that patient. Most of the time, it is thrombolytic therapy that we're going to be recommending. However, there are patients who are not candidate for thrombolytic therapy for all reasons. And if they're not candidate, then we figure out between Ehab and myself and others, we figure out what's the best approach, whether mechanical or surgical extraction. If we do surgery, if the decision is to go to surgery, then this is done through a median sternotomy. And the advantage of surgery is that we can get a complete extraction of all the clots. And there's a technique that we use here where the pulmonary veins will be clamped and will flush from the pulmonary veins through the lungs out from the PA, and it's not enough pressure to push out the clot, but when you go in and find a clot and start grabbing the clot has no integrity when it's acute, but having that backward flow and backward pressure allows the whole clot to come out in one piece, and you get a complete extraction that way, and the hemodynamic effect that you see is completely dramatic. There are patients who are not stable enough or who are crashing and burning in front of your eyes, and those are the patients that will put them on ECMO because that's the fastest way we can stabilize a patient. But ECMO in itself for this group of patients is not the end treatment. It's a bridge to something more definitive, either to surgery, or if they're not a surgical candidate for any reason, then Dr. Haddad here will take them for mechanical thrombectomy or catheter-directed lysis.
So, there's a lot of tools, or have been a lot of tools in the armamentarium of the interventional teams. What are you using now? What do you prefer? How do you sort of separate the groups and decide what to do?
Yeah, so the biggest distinction is whether you're going to do a pharmacologic endovascular treatment or some kind of a mechanical treatment. We have the best, it's not necessarily the highest quality data, but certainly the clinical trials that have been published that gave us a good algorithm is with the pharmacologic catheter-directed delivery of thrombolytics. So we tend to favor that route for patients that have a clot burden where the distribution makes sense to do a catheter-directed lysis for. The patients that can't get thrombolysis, can't go to the operating room. If there's hemodynamic instability, those are the patients that we typically do the mechanical thrombectomy. The endovascular technology has lagged behind, so the catheters aren't really optimized. So it's not quite to the point where I would say every single patient should get this. But if this is a patient that doesn't have very many options, we are able to offer that. I think having ECMO capabilities here at the clinic buys us an extra safety margin. There's certain tools that we normally can't use or can't use as safely without ECMO that ECMO allows us to use, but that's the algorithm that we typically follow.
So I want to segue into the management of the chronic thromboembolic pulmonary hypertension patients, and sometimes I hesitate even adding pulmonary hypertension to the diagnosis because they can come in such a broad spectrum and have other sort of pulmonary disorders. Gus, when you look at these with your wealth of experience, how do you think through working up and assessing patients who might have CTEPH?
Yeah, so I think there are sort of three main patient populations where we need to think about chronic thromboembolic disease. The first one is patients with established pulmonary hypertension, where you always have to screen for thromboembolic disease because of the available treatment options that we currently have. And so the screening test of choice for that is the ventilation perfusion lung scan. And we typically complement that with CT pulmonary angiography or invasive pulmonary angiography.
Seems so old-fashioned to use a VQ scan.
But we always go back to it because it, in multiple studies, has been shown to be the most sensitive test. But also, interestingly, we use it a lot to guide our treatment decisions because when we see big perfusion defects with preserved ventilation, we feel pretty good about revascularizing these patients. So patients with established pulmonary hypertension are a big cohort of patients where we really need to think about chronic thromboembolic disease. The second cohort of patients is those who survive acute pulmonary embolism. And with availability of these multidisciplinary teams, we also now have these post-PE follow-up clinics where we want to make sure that within 3 months or so of the diagnosis of acute PE, patients go back to normal, the symptoms go away, the right side of the heart, as you were saying, if the right heart is enlarged and dysfunctional, we want to make sure that that goes back to normal. If it doesn't, within 6 to 12 weeks of anticoagulation, you need to start thinking about chronic thromboembolic disease. And the third one, as you were pointing out, we are now seeing an increasing number of patients who have chronic blood clots, shortness of breath, without resting pulmonary hypertension, so-called CTEPH, or chronic thromboembolic disease. And so I always tell people that if you have a patient complaining of shortness of breath, and after, the usual workup, you end up with no diagnosis, then screening for chronic thromboembolic disease with a ventilation perfusion scan is a good thing to do because even with a normal-looking echo, without evidence of pulmonary hypertension, we have seen a lot of patients with symptoms due to chronic thromboembolic disease that, you guys can operate and improve significantly.
My experience, correct me if I'm wrong, is it tended to be unilateral disease. Was it just a skewed population, or is it more commonly a unilateral?
No, I think that's probably an accurate observation. I think as we see more and more of these patients, we're learning more about them, but it is quite interesting to see that a lot of those patients tend to be unilateral disease. My personal observation is that we have seen also this in women and obese patients as well. But I think, the data and experience is accruing before we can make, more generalized comments about that.
So, Mike, it's one of the more challenging cases we do in cardiac surgery, managing somebody with chronic thromboembolic disease. Tell us a bit about what are some of the challenges in the technical and the management aspects of this operation.
So in the operating room, this is an operation that requires circulatory arrest. And we do this through a median sternotomy, and once we're on bypass, we'll cool the patient down to about 18 degrees, and then we will go circulatory arrest. And typically I start from the left side. The pulmonary artery will be exposed, and we go in. And the key really, as you had taught me, is finding the right plane. You got to find the right plane between the scar tissue and the intima of the vessel. And once you find the right plane, then you could carry that dissection down to the smaller and smaller branches. And once you get far enough that instruments can't physically get to, and then at that point you can start pulling on the scar, and it comes out like a piece of spaghetti. And you would do that for each subsegmental branches, and you come out with almost like an octopus, like a piece of scar. And typically what we'll do is start on the left side. It takes about 15 to 20 minutes on the left side. Then we'll reperfuse and close the left pulmonary artery, and then go to the right side. And then from the right side, we'll repeat the process, and then we'll rewarm the patient back up. So the operation in itself is mainly the getting into the right plane so that we can do a complete extraction. Post-operatively, there are other considerations to get a good outcome. First of all, we want to make sure we're not hyper-perfusing the lungs afterwards. Often these patients have RV dysfunction, and the tendency is to want to put these patients on inotropes, and the key here is we don't want to do that. We would tolerate a lower cardiac index, about 1.8 to 2, just so that the lungs are not being hyperperfused and to prevent lung injury. Well, in the cases where we still have some residual pulmonary hypertension, we'll use a pulmonary vasodilator such as isoprostanol, inhaled isoprostanol to help bring the pulmonary hypertension down. And then also afterwards, we have to manage anticoagulation. A lot of, as Jerry had mentioned, a lot of these patients are now coming on DOACs, and whereas before we would post-operatively put all these patients on heparin and Coumadin, and we found a lot of these patients would develop pericardial effusions and pleural effusions, and now we just put them on sub-Q heparin, and we'll start them on their DOACs on post-op day 3, and it's worked very well. And with a much
simpler.
Yeah, much simpler and a lot less complications.
And am I accurate? You've done 13 or 15 so far this year?
Yeah, we've done about 15 this year.
15, and the expectation, as I recall, Gus and Mike, the operative mortality at Experience Center on all comers should be under 5%, probably under 2.5%. Is that an accurate?
Yeah, that's correct. So if you look at the report from the International CTEPH registry, their mortality was 4.7%. In our group right now, our operative mortality is around 3.2%, so it's actually better than the International CTEPH registry. And certainly the benchmark, I think, in general, when the latest guidelines were published now about 5 years ago, they recommended less than 7%, but I think the field has moved to, if you're going to be doing endarterectomies, your operative mortality needs to be below 5.
I would say 5. And a few years ago, we didn't even think about using balloons to dilate the distal ramification of the pulmonary artery. Yeah, where are we at on that? Where do you see that field going? It seems like a great opportunity.
It's a great opportunity for growth, but I still am fascinated by the fact that I hear you say, oh, in about 20 minutes we're done with the left side, and and then we do the right side another 20 minutes, because from an endovascular approach, it really is, we have a lot of ways to go. Sometimes it takes 20 minutes to get into that segmental branch to treat it, and we're looking at the X-ray, not the actual artery, so we're kind of guessing what the artery is supposed to be. There's a role for it. I think there's some anatomical distribution that might favor one technique versus the other. We're still in the early part of our experience in terms of deciding what's the best approach, how often and how aggressive, and when do you stop.
Yeah, for sure. No, those are great points. Well, I want to thank the panelists. I think if I take away I guess one important point or a couple important points from the management of acute pulmonary emboli and the PERT team, to the management of the complex chronic patients, a dedicated multidisciplinary team of physicians that are committed to this field, because it is a complex, challenging field on all fronts, is what's necessary really to drive outstanding patient outcomes. So I want to thank you again for spending the time with us today.